Okay, we'll end this unit talking about the pediatric circadian rhythm disorders and insomnia. Let's refresh ourselves on the circadian rhythm. Entrainment to night and day occurs in utero passively in response to the mother's release of melatonin and core body temperature. What? The baby or fetus, while in the womb, passively, meaning they're just there when it happens. They get they're exposed to melatonin from the mother, and they're exposed to the core body temperature of the mother. The suprachiasmatic nucleus is the circadian rhythm pacemaker. It's part of the brain that's connected to the eye via the retinohypothalamic tracts where our brains know when there's light and darkness. The SCN develops early in gestation, and although there is passive entrainment in utero, it does not fully entrain the infant, and they also have different sleep needs than adults. So, the temperature factor of entrainment happens within the first week, manifesting in higher temperature in the morning and lower temperature in the evening. Melatonin does not really start its effects until a month and a half outside the womb, with more melatonin in the evening. During the second month, infants begin to have 90 to 120 minutes of sustained wakefulness without falling asleep. By day 60, the infant begins the nighttime sleep period as the sun goes down, possibly owing both to light cues but also family or social cues as most people go to sleep at night. There is a point in the evening prior to the nighttime sleep period where sleep is least likely to occur. We refer to this as the forbidden zone of sleep. It occurs somewhere between 1 to 3 hours before the intrinsic rhythm, most likely between 5 and 8 p.m. This occurs due to the circadian processes through which peaks during this time inhibiting sleep, as well as the sleep pressure or homeostatic drive. The homeostatic drive works opposite of the circadian rhythm, meaning sleep pressure increases as the day goes on, and the circadian rhythm makes us more wakeful as the day goes on. Circadian rhythm sleep disorders occur in approximately 10% of children. Typically, it's delayed sleep phase syndrome in children. Remember that delayed sleep phase means going to sleep later and waking up later. We are delaying the normal schedule by a few hours. I also try to remember the difference between delayed and advanced sleep phase by thinking patients of advanced sleep age show advanced sleep phase, where older people go to bed earlier and wake up earlier. Specifically, delayed sleep phase occurs when a person goes to bed at least 2 hours later than what is considered normal, and it is often mistaken for insomnia. What is normal anyways? I guess a lot of people would say somewhere between 9 and 10. It occurs in about 5 to 10% of adolescents and usually begins around school age. If the person has to get up, for example, to go to work or to go to school, they may be depriving themselves of sleep because their phase is delayed. And this can result in something called sleep drunkenness. This is pretty typical thing to happen to teenagers, not only because of things like FOMO, fear of missing out, or heightened social awareness. They don't want to miss out on anything that maybe their friends are doing. They're going through puberty, and many changes are happening that can affect different chemical processes, including sleep. There is also delay in the low point, or nadir, of the temperature and release of melatonin, causing the person not to feel sleepy yet. Delayed sleep phase disorder can be accompanied with symptoms like hunger near bedtime but not eating breakfast, being hard to wake in the morning, falling asleep at school, bedtime struggles, and behavioral symptoms like ADHD or depression. Sometimes the earlier awakenings from work or school will cause sleep deprivation, which can exacerbate ADHD or depression symptoms. Oppositional defiance disorder, or ODD, is a feature in children that includes ongoing patterns of uncooperative, defiant, and hostile behavior towards authority figures, which seriously interferes with the child's day or day-to-day functioning. If the person is able to sleep late on Saturday and Sunday mornings, Sunday evening can be difficult because the sleep pressure is not sufficient to trigger sleep onset, as well as the out of sync rhythm, making Monday mornings tough to slog through. Treatments for delayed sleep phase include adjusting the body temperature nadir, or when the core temperature is at its lowest. Typically, we want to see the nadir about 2/3 of the way through the nighttime sleep period, and light therapy can help with that. When you're exposed to light before the nadir occurs, it causes a phase delay, or feeling sleepy later. When you are exposed to light after the nadir occurs, it will cause a phase advance, or feeling sleepy earlier. Bright light exposure for between 1 to 2 hours in the morning also assists in entrainment via the retinohypothalamic tract, where the brain sends light signals, where the eye sends light signals to the brain, thus adjusting the rhythm. Physical activity in the morning is also likely to create more sleep pressure for later in the day. You can place the bed in a room with a window that has direct light from the east, since the sun rises in the east in the morning. After sunset, artificial light sources should be avoided if possible. This includes TV, cell phones, tablets, and bright fluorescent light bulbs. Red spectrum light is the best light for the evening, since that mimics the light at sunset. Blue is more common in the morning. In order for this treatment to come together and work, it must be followed as strictly as possible. This includes weekends and holidays. The circadian rhythm doesn't take off, so neither can you. Sleep hygiene in individuals who are highly motivated to alter their rhythm is the most important aspect of their treatment. If they follow the suggestions and integrate them into their sleep hygiene practices, they have a better chance of success. One diagnostic tool to estimate when the child's temperature nadir occurs is to ask them to keep a diary of when they would sleep if they were allowed to do whatever they want, whenever they want. If they list a specific bedtime, this could be an indicator to when their nadir is. For example, if they want to go to sleep at 4 a.m. and wake up at 2 p.m., then their nadir is approximately 11 a.m. If they're exposed to light before 10 a.m., there is a further phase delay. That's a great idea for some kids. A lot of kids are going to say, I'm going to sleep all day, or I'm never ever going to sleep. So take it with another grain of salt. For light therapy, blue light boxes are most commonly used, but if it's summer or spring when the sun is closer to the earth, the sun can be a good natural way to adapt. With using the sun, you can't wear sunglasses, but at the same time, you want to be careful not to look at the sun, obviously. You don't want to be in the sun for too long either. The sun's really bad for your eyes. It's really the ultraviolet rays that are bad for your eyes. They can cause cataracts. As well as you want the sun to come in through your skin because you're absorbing vitamin D through the sunlight. But if you do it for too long and at the wrong time, you'll get sunburn. So be careful with the sun. Melatonin is an over-the-counter supplement that mimics the naturally occurring neurotransmitter from the pineal gland. It is known for lowering body temperature and decreasing metabolic rates. It should be administered approximately 1 hour prior to sleep, as well as making efforts to block light. Melatonin is not a sleep aid for long-term usage. In fact, I've spoken to elite sleep professionals that only recommend microdosing melatonin instead of the bigger doses available because people think it will just induce sleep. Sometimes, more melatonin can have the opposite effect, especially if it's taken too early or too late, or if the dose is just too much. We do know that melatonin supplements can cross the blood-brain barrier, so it's just really an issue of when and how much. Chronotherapy, meaning altering the schedule of the day, bedtime is constantly delayed 3 hours each night, causing a 27-hour day. This continues until ultimately the bedtime that you want is achieved. Typically, parents are the ones who complain about children not sleeping or over children not sleeping. I think a lot of parents are ready to get some me time and the kids should be sleeping, so what's the holdup? Well, some patients won't fall asleep at bedtime, others have no trouble falling asleep, but they wake up throughout the night, and others have problems with both. There was a study, the California Assessment Program Student Achievement in California Schools, that showed that children who had a longer duration of nighttime sleep showed superior school performance and higher intelligence scores, and specifically, more sleep, better school performance. Uh, that's very simple and it sounds nice, but that's not exactly how it works. If you give a child the best sleep they can, they reach their full potential. Duration is cut by each minute the child stays awake past their bedtime, especially if the bedtime is connected to a scheduled wake-up time. Less sleep duration may eventually lead to sleep deprivation symptoms during the day. Teachers may notice sleepiness or children falling asleep or having general hyperactivity, which may be unusual for the age. Insomnia can be secondary due to many health conditions or sleep disorders. The child may not be able to fall asleep due to coughing from cystic fibrosis or asthma. Autism frequently results with children lying awake and appearing active through the night. The child could be suffering from other sleep disorders like sleep apnea, movement disorders, parasomnias, or delayed sleep phase disorders. Not to mention nightmares. If you kept going to sleep and seeing scary things, wouldn't you try to stay awake? The same thing goes for parasomnias. They themselves do not cause insomnia, but a child may develop a fear of repeated situations that could cause insomnia. Kids have a lot of nighttime awakenings and arousals, but they still generally get enough sleep so that it is rare for kids 5 years old or younger to have significant sleep deprivation. It can be difficult to analyze data for nighttime awakenings, but when parents are asked, they usually note when the child is awake and needing attention. One such study showed 23% of 1-year-olds wake up, 24% of 18-months-old wake up and need attention. Stress at home or at work or school can contribute to increased sleep interruption. It can also wind up as a chain reaction because when a child wakes up at night, so does the parent or parents, which lead to dual sleep deprivation. That can really stress a parent out, and irrationality can happen with dealing with children at night. Children's arousal thresholds differ between children and with age. As infants or babies, they may have a very immature arousal mechanism which leads to SIDS. The sensory threshold means how much of a stimulus is needed to make a child's brain react. Like when they're asleep, how loud of a noise do you have to make for them to wake up? Again, that varies with age and personal characteristics. Children that have low daytime sensory thresholds, or those who react to even quiet noises or touches, may also have a low arousal threshold, meaning they can still wake up easily. The same can be said with children who don't respond quickly to certain stimuli when they're awake. They might not respond easily to nighttime stimuli. These are some situations that may or may not induce insomnia. Sometimes people fall asleep for a brief moment, called microsleep, and then they arouse with a small noise. If that happens enough, they will just stay up. It's also going back and forth between brain states, and when you keep arousing, like with sleep apnea, it can cause awakening and insomnia. There are a lot of things to consider when confronted with pediatric insomnia. How old a patient is doesn't mean they will absolutely mimic the stereotype. Mental age can be different than physical. What would be considered a normal night for the patient? Is this a developmental thing where they are going through sleep regressions? Are they showing signs that they are lagging behind in circadian rhythm entrainment? Is the patient suffering from any other medical or psychiatric problems? Pain is classic for causing insomnia. When the patient is experiencing insomnia, what do they do or how do they act? What do they do to eventually fall asleep? How does this all relate to better night's sleep? Remember, kids are always growing and developing. There are a lot of changes happening, and they can occur swiftly, causing things like insomnia. Just like with adults, almost everyone experiences a little insomnia here and there, but when it happens over and over, that can be a problem. Just about everyone is allergic to cow's milk, or as we know it, as lactose intolerant, but some people just tolerate it better than others. With infants and small children, it can cause disturbed sleep patterns because of the symptoms of the allergy. It can inflame the tonsils and adenoids, causing a higher likelihood of having sleep apnea. It can cause the oversupply of mucus in the throat. Babies can be fussy during the day, may be anemic, or show hematochezia, which is the passage of bright, reddy, bloody stools. This is different from melena, which is stool with blood that has been altered by the gut flora and appears black and tarry. Hematochezia is commonly associated with lower gastrointestinal bleeding. That would be why the blood is brighter red, because it has not gone through so much processing in the digestive tract. Once these patients no longer have cow milk, their sleep can return to normal in about 2 weeks. Colic is a condition where infants and young babies exhibit violent, inconsolable screaming attacks later in the evening. There's no definitive diagnosable cause for colic, but it's thought to be due to an abnormality in gut flora. It can cause frequent awakenings and brief daytime naps. It can show up near the end of the first month and usually ends between the second and fourth months. There isn't much to do other than be a nurturing, supportive, and calming influence on the baby. However, keeping to consistent sleep routines post-colic is critical for early entrainment and remission of insomnia. Insomnia due to a medical condition would be considered secondary insomnia instead of primary insomnia because there's a reason for it. For children, some more common reasons for insomnia would be otitis media, complaints of otalgia, specifically ear pain from ear fluid pressure. Remember, pain is an intense sleep inhibitor. It's very hard to sleep through that kind of pain. Sometimes ear pain won't show any other symptoms except for sleep disruption, making it hard to diagnose, especially when the kid's really young. Attention deficit or hyperactivity disorder in young children can make them easily distracted. They can have rapid mood swings and may cry easily. This may be associated with a sensory disorder relating to a low arousal threshold, meaning easily to awaken. This can cause restless sleep and nighttime awakenings. It's important to make the distinction between what the cause of the symptoms are and what the resulting effects are. It will help a diagnosis, but also your patients knowing a child can't help it. Children can be hyperactive because they are just young, or because they are sleep deprived, or because they have ADHD, among other reasons like sugar and caffeine. Patients with obstructive sleep apnea may show signs of ADHD, although in this case, ADHD wouldn't be the diagnosis because obstructive sleep apnea is causing the sleep deprivation causing the ADHD. If the ADHD is still there despite fixing all the sleep problems, then you treat for ADHD. Otherwise, chronic illnesses like asthma, which causes coughing, GERD, which the heartburn can cause pain and discomfort, can keep children awake also. Children may experience insomnia due to psychosocial factors like affective disorders, specifically depression. Depression can cause cyclic thoughts of shame or guilt or just blue feelings. Occasionally, the patient will sleep during the day more with naps, causing insufficient sleep pressure for the nighttime, therefore causing insomnia. It can cause disturbances of sleep continuity through early morning awakenings, problems settling, nocturnal arousals, decreased sleep efficiency, and shorter REM latency. Kids are also afraid of things, especially in the dark, and those are normal for the most part. However, if the child is screaming because they are terrified of their dreams, a psychologist may be needed to find the source of the real anxiety. It's becoming more and more clear that many severe mental health disorders later in life are triggered from childhood trauma. Children who are severely abused may learn to dissociate during stressful events and may exhibit multiple personalities to deal with different scenarios. Children who are made to feel guilt or shame about naturally bodily processes may go to extraordinary lengths to combat it. They may develop body dysmorphia, or they may be delusional about what they look like. Parents who expect perfection from their children will create perfectionist children who see everything as wrong or not good enough. And this just scratches the surface on the many ways an environment can impact a child's future. Behavioral insomnia is a specific insomnia that children exhibit based upon their need for certain things to fall asleep, like a special blanket or toy, or the lights have to be a certain way, or there has to be a routine with mom and dad before we try to go to sleep. For about 6 months, when my daughter was like 2 or 3, when I would carry her to the rocking chair to be rocked to sleep, we had a routine. We had to do a high five, a fist bump, a fist five, which is a fist bump and a fist high five put together. She did. An ugga mugga. We have to shake our hands, then we hold the hand, and then we say goodnight, I love you, and have a good sleep. We had to do it in that order, or we had to start over. And that was our compromise. That was the most that we allowed. Clara would try and eventually add more things, but we stuck to our routine. After a while, it slowly changed into she just didn't care about all those things anymore, and she just stopped doing it. Funny, because it was a bittersweet moment because I had gotten so used to it that it was a little sad when it ended. For other parents, it might be needing sound or TV on in the background. It's not a problem until the child becomes a tyrant or asks for things they can't get if the conditions keep delaying sleep further and further, or if the only answer is to give the child a sedative, which personally seems pretty extreme. This occurs in about 10 to 30% of children. The issue can also become that the child will not sleep until these things are there. So if something happens and the TV won't turn on, or you're on vacation and you don't have the normal environment, that child may have a really hard time falling asleep. They get used to it, though. They should eventually let go of those things, or if the parents give in too much or don't hold their boundaries, they may transfer that need to something else. Limit-setting behavioral insomnia is when the child refuses to try to go to bed or continues to stall, or as I like to say, filibuster, or waste time, and that this is on the parents not setting limits and boundaries. When boundaries are set, you have to stick to them. When you relent, the parent or the child recognizes that you can be changed, and they will remember that and try it with other things. If they cry louder and louder and that gets a different response, they figure that stuff out. They're smart boogers. This behavioral insomnia can be discerned from delayed sleep phase if the child eventually does go to sleep at a later time, especially if it's at the same later time. You can have a mix of both limit setting and behavioral type of behavioral insomnia in combined type. For treatment, you can try behavioral modification. The child will most likely be resistant, which is a nice way to put it. But the child will eventually have to sleep alone for a little while if the parent does not go to bed at the same time. As long as the parent can escape the room without waking the child and use a monitor, they can still check back in. Eventually the child will wake up, but they will always have the comfort in knowing that a parent always comes back, and they will learn that over time. I would consider that part of proper sleep hygiene, but for insomnia treatment, we can keep them separated. If you can find a provider to give a child medication for insomnia, they may use chloral hydrate or Phenergan. This is controversial, but I have seen it. I've seen children on Valium for insomnia. Not movement disorders, but just for insomnia. It's very controversial for developing brains. If used, it needs to happen real quick, and it doesn't need to be for long term. Sedatives and hypnotics and children make me very, very concerned. It reminds me of the Casey Anthony case and how she would drug her child for naps. She called it Zanny the Nanny because she used Xanax. Not to say all parents who give their children sedatives are like that, but I'm very much at the point where sedatives have to be a measure of absolute last resort for serious problems, which I guess, since we're sleep professionals, this is where we'll see it. So what are the key elements for good childhood sleep hygiene? First, ensure that the bedroom is dark, quiet, and cool. If there is environmental noise, the use of white or brown noise can be used. Music can be used also, but sometimes music can be too interesting and more arousing than sedating. If you choose music, it should be maybe instrumental, something classical with no words. Cooler is better than hot because you can only remove so many clothes or blankets, but you can always add more blankets if you're too cold. Keep the bedtime routines and times the same. Even little things like a night out that goes past the time that the routine's supposed to start can regress a child's sleep progress. Mornings should also have a routine of waking up at the same time. Waking up later can push back the bedtime routine due to reduced sleep pressure. No one should go to bed hungry. When people are hungry, they should eat. This should be different between eating when you're hungry and eating when you're bored. Kids usually want something to eat before bed. But before bed, try to limit water, but don't restrict it. No excessive water. You don't want to dry them out too much. The child may require parental support to fall asleep, but they should be able to sleep in a room without the parent there. Exercise should be limited to an hour before bedtime. They definitely need to get that energy out, but not too close to bedtime. If the child naps, they need to be scheduled carefully. Napping too early in the day may make the child want to sleep earlier in the evening, causing a super early morning wake up the next day. If they nap too late, they lose sleep pressure to go to sleep at the right time. No caffeine several hours before bed. Kids have enough energy to live without caffeine, really, but you have to realize that there's also caffeine in chocolate or medications. Even if, they're not drinking coffee or tea or soft drinks, they still get it other places. So, behavioral modification sleep training is related to the cry it out method, and it's controversial to a lot of parents, including this one. Personally. Why must children learn to go to sleep on their own at a specific age, and what age is that? It seems like it's pretty arbitrary, just like PG-13. Most children under 13 years old watch those movies, and what's the magic thing that happens when the children turn 13 that makes it okay for them to watch content that a 13-year-old should watch? Truly, children sleeping alone is an issue for parents who want convenience. When children are ready, they will want to sleep alone. My little girl wanted to start sleeping alone when she was 3 years old, and my wife had a really hard time with that, which was the opposite problem, I guess you would say, to this situation. But the child must learn to sleep, must go from sleep to wake without help from the parent. Some studies say it usually takes less than a week, but the child may regress naturally, and let's face it, every child is facing different and every child is different, and none of them resemble anything in any textbook I've ever read. Consistency and persistence is the key. The first night may take hours before the child is asleep. You've got to warn parents that this may occur and that they should be prepared. This really isn't something sleep technologists instruct parents with, but these are the guidelines for this type of sleep training, and you might find out about that sleep training when you're running studies. After all, how do you train a normal biological process to do something that's against the intrinsic behaviors that were set in our ancient ancestors? Throughout the whole process, parents have to be supportive. The child needs to know that there is a parent nearby and is understanding. When does one sleep train their child? I've heard 4 to 6 months, which sounds that's really young. I know all families are different, but it seems strange to set your baby in another room without you. There is this is not conducive to attachment parenting, which is generally regarded as the best method for raising an emotionally well child. It's been shown that when babies continue to cry for their mothers, it experiences an increase of the stress hormone cortisol. The mother also has to be awake to respond to the baby if they don't stop crying. There is a lot of misleading information. For instance, sleeping through the night is generally means midnight to 5 a.m., and that's hardly the whole night when it comes to a kid. Crying is the baby's only defense, and when it's not heeded, the bond between parent and child is diminished. If you don't go in every time the child cries, maybe it's that one time that the child is crying because there's actually something wrong, but you're sleep training and you won't go in there. Overall, parents make the choice to sleep train or not. Children sleeping in the same room or even in the same bed as parents is not as dangerous as a lot of people make it out to be, even a lot of pediatricians. Unless the parents have some sleep problems or arousal problems, suffocation is just incredibly rare. And in the end, it seems like it's convenience versus care. All right, so that's enough of that. Babies and all their things that we have to worry about as parents. What are you going to do? Study hard. That's what you do, all right? Well, that's it for this unit. We will have the exam sometime, probably a couple weeks or so. Work hard. If you need anything, text me, give me an email, something like that, and I'll get back to you. Alrighty.